now that we've completed that septum, we now have the right ventricle flowing directly into the pulmonary trunk, and the left ventricle flowing directly into the aorta, deoxygenated blood going to the lungs, oxygenated blood going out to the body. And so that's the normal development. So now let's turn our attention to the most common of the cyanotic defects. I mean, up until now, the defects that we've talked about, we spent a lot of time talking about atrial septal defects, and we made the point that that's an acyanotic defect because it's a left to right shunt. I mentioned that when you have an isolated ventricular septal defect, that's also a left to right shunt, so that's also acyanotic. And so what we can say is that the most common of the congenital heart defects, ventricular septal defects and atrial septal defects being the two most common, are both acyanotic or non-cyanotic defects. But now let's turn our attention to the cyanotic defects and start off by talking and using as a model the most common of the cyanotic defects, and that is called tetralogy of Fallot. Tetralogy of Fallot is the most common of the cyanotic defects. And before we take a look at how it forms, let's review what tetralogy of Fallot is. Tetra means four. So there are four elements of tetralogy of Fallot. The four elements are pulmonary stenosis, overriding aorta, ventricular septal defect, and right ventricular hypertrophy. Those are the four elements of tetralogy of Fallot. And what we want to do now is take a look at how that happens, with particular attention to the question of why do those four things happen together with such a high frequency as to result in this being the most common cyanotic defect. Why do those four things happen together? And as we'll see, the answer to that question is that it really isn't four things. It's one thing that happens that results in looking like four different things, but it's really one defect. And that defect is going to be a defect in the formation of the aorticopulmonary septum. So let's take a look at what happens in tetralogy of Fallot. We said that normally the aorticopulmonary septum forms right down the middle. And that was what resulted in there being equal size outflow vessels, and that's what resulted in it fusing with the embryonic ventricular septum. Well, in tetralogy of Fallot, what happens is the aorticopulmonary septum doesn't form down the center, but rather it forms displaced toward the pulmonary side, toward the right side, like that. Sometimes that's referred to as dextropositioning. Dextro means right. Dextropositioning of the aorticopulmonary septum. As a result of that septum being displaced toward the right, that means instead of having two equal size outflow vessels, we have two unequal size outflow vessels, with the pulmonary trunk being too small and the aorta being too big. So the pulmonary trunk being too small results in the pulmonary stenosis that we said is an element of tetralogy of Fallot. The aorta being too big results in the overriding aorta. That is the second element of tetralogy of Fallot. By overriding, it means that the aorta is so large that it straddles both ventricles. It's overriding both ventricles, both the left and the right ventricle. So that's the second element. The third element was ventricular septal defect, and we see that because this septum is not lined up with that septum, they don't meet, they don't fuse, and therefore you have a ventricular septal defect. So that's the third element of tetralogy of Fallot. The fourth element, which we said was right ventricular hypertrophy, really isn't a defect. The right ventricle, or the right ventricular wall, is having to work very hard because of the pulmonary stenosis. In order to try to pump blood through the stenotic pulmonary valve, there's going to be a lot of work demanded of the right ventricular wall, and when you demand a lot of work of muscle, the muscle hypertrophies. So that's a normal physiological response to the defect. So the right ventricular hypertrophy, which is the fourth element of tetralogy of Fallot, really isn't a defect. What it really is a physiological response to the structural defects. The structural defects are the pulmonary stenosis, the overriding aorta, and the ventricular septal defect. Now, as a result of this defect, what we can see happens is that the oxygenated blood from the left ventricle certainly is able to flow out to the aorta. But the deoxygenated blood that's in the right ventricle, some of it will be able to get out into the pulmonary trunk, albeit through a narrowed opening, but a whole lot of it is going to get shunted from the right ventricle through the ventricular septal defect into the overriding aorta, and therefore mix with the oxygenated blood. So both deoxygenated and oxygenated blood is getting into the aorta. That indeed is a right to left shunt, and we've already said that right to left shunts are cyanotic, so the presence of deoxygenated blood in the systemic circulation will indeed result in cyanosis. So that's the most common of the cyanotic defects, and as we said, it is a defect in the position of where the aorticopulmonary septum forms. Another cyanotic defect that's also related to the aorticopulmonary septum is called persistent truncus arteriosus. And in persistent truncus arteriosus, what happens is that the aorticopulmonary septum doesn't form at all. And if you don't form an aorticopulmonary septum, that means that the truncus arteriosus doesn't get converted into an ascending aorta and a pulmonary trunk, but rather remains as a truncus arteriosus. And therefore, blood from both ventricles will flow into this common outflow pathway, will mix, and therefore you will have deoxygenated blood getting into the systemic circulation, just as you'll have oxygenated blood getting into the pulmonary circuit. So you'll get a mixture of blood going into both circuits when this trunk eventually divides further distally. Okay? So that clearly will also be a cyanotic defect. Now, the other thing we can see is that when you have a persistent truncus arteriosus, you will always have a ventricular septal defect coexisting with it, because the aorticopulmonary septum should be the source of the membranous portion of the ventricular septum. So if you don't have an aorticopulmonary septum, you won't have a membranous ventricular septum, so therefore you'll have an incomplete ventricular septum. Only the muscular part will be there. So there is always a ventricular septal defect when you have persistent truncus arteriosus. So that's a second cyanotic defect, also resulting from an aorticopulmonary septal defect. I'll point out right now that the aorticopulmonary septum has as its major embryonic component neural crest cells. So again, here is an important set of defects that can coexist with other neural crest migration defects. This is another place that neural crest cells migrate to. Now, let's go back and deal with that issue of how the aorticopulmonary septum actually forms in the shape of a spiral. If we look at these illustrations from your notes, what we see is that in the formation of the aorticopulmonary septum, it forms by ingrowths from the wall of the truncus arteriosus, and the position of those ingrowths changes as we go from proximal to distal. And we don't have to spend a lot of time understanding that. That's a little bit conceptually difficult for many people. All that we need to realize is that it is, as a result of how it forms, it ends up in the shape of a spiral, such as seen here. And as a result of that spiral, we see that the blood from the left ventricle ends up going up to the right, to the front, back to the left, and then blood from the right ventricle goes up and to the left. And so, as a result of that, when that septum finishes forming, the two outflow vessels, in fact, have the appearance of spiraling around one another. So you recall we talked about the oddity of having the ascending aorta, which arises from the left ventricle, going up and to the right, whereas the pulmonary trunk, which arises from the right ventricle, going up and to the left. And now we see that the reason it's like that is because the septum that has separated those two vessels from one another is in the shape of a spiral, and therefore the two vessels end up spiraling around one another. So that's why it forms the way it does. Now, there is another defect relating to the aorticopulmonary septum, and that defect is one in which the aorticopulmonary septum does not form in the shape of a spiral. but rather forms as a straight septum. So if the aorticopulmonary septum doesn't spiral, what would be the effect on this adult structure? Well, these two vessels would not spiral, and therefore, if we took a look at where the root of the ascending aorta came from, it would come out like that, straight, not spiraled. And similarly, the root of the pulmonary trunk would come out straight and not spiraled. And you see that would mean that the aorta is coming out of the right ventricle and the pulmonary trunk is coming out of the left ventricle, which means that the pulmonary trunk would carry oxygenated blood from the left ventricle and carry it to the heart. And the aorta would carry deoxygenated blood from the right ventricle and carry it out to the systemic circulation. So we would have two entirely separate parallel circulatory systems, one carrying deoxygenated blood, one carrying oxygenated blood, with no crossover. Now recognize that prenatally this would not be a problem, because prenatally the blood on the right side of the heart is oxygenated blood because it's coming from, in large part, from the placenta. So you'd have oxygenated blood on the right side going out to the aorta. So that's not a problem. But postnatally, as soon as the baby is born, when the source of oxygen becomes the lungs, what we see is that we now have a big problem that we have no source of oxygenated blood to go out into the aorta, to the systemic circulation. And one would expect, therefore, that any time you had this defect, these babies should die right after they're born. But that doesn't happen. Now, this defect is given the name transposition of the great arteries. This defect is called transposition of the great arteries because the two vessels are, in fact, transposed. And as to the question of how come babies are born alive with this, and in fact, it's a not uncommon, it's somewhat less common than tetralogy FLO, but it's not that uncommon. The question is, how come they're born alive? And the answer is that there must be other defects that coexist with transposition that allows for mixing between the right-sided and left-sided circulations. If there were no other defects, these babies would die immediately upon birth. But if they're alive, that means there are other defects that are allowing for shunting of blood. And in this case, those other defects are a good thing because that's what's keeping the baby alive, at least keeping the baby alive long enough to allow for surgical switching of those two vessels, which is what is now done as a definitive therapy.